Good evening, all. Welcome to the fantastic episode of Top, that is Tips in Office Practice. Generally, friends, we have seen so many years we have been working. When we start as a first beginner, we are alone. We are in medical practices, medical institutions. So many our colleagues are there to help us. And when we start our practice, we do not have anybody. Our mind, which is fresh, and we require a lot of actually support. And this support has been given by constantly by MahaAP through these tips in office practices. This is a wonderful program where when we are working alone, we get the tips how to deal with the patient when you are alone and who can manage the patient without any, I would say, adverse effect in our practice also, and we get a good name also. So, friends, I request you to continue this journey of these tips in office practice to gather our information as well as knowledge more and more, and we have wonderful faculties each and every time. So I request our dear President Dr. Ram Gopal sir to start with the session with his fantastic thoughts. Sir.
Thank you, Dr. Satish. Good evening, friends. Welcome to another episode of Top, that is Tips in Office Pediatric Practice. The title already Dr. Satish has explained you. Now I welcome our CIP EBs Dr. Sanjeev Joshi sir, and he is the coordinator of this program. So thank you, Sanjeev Joshi sir, and welcome. And I welcome Dr. Jitendra Gawane. He is EB from MMR. Welcome, Dr. Jitendra.
Welcome, sir. Welcome.
Friends, as the name itself suggests, we will get the tips from our in a day-to-day practice. So for today's topic on snake bite, we are going to get the tips from Dr. Sanjay Joshi. He is from Pune. Welcome, sir. And another person who is Dr. Bakul Parikh, sir. He doesn't need any introduction. Sir is stuck in the traffic, so he would be joining in some 10 to 15 minutes. So we will welcome him that time. Over to you, Satish. Satish.
Thank you, sir, for encouraging words. I request our dynamic secretary, Dr. Amal Pawar, sir, to give some thoughts.
Thank you, Dr. Satish, sir. Thank you for accepting to be as a moderator for this wonderful session, which involves two of the senior academicians of Maharashtra IIP, Dr. Sanjay Joshi sir from Dhule, my nearby district, and my mentor. And I have learned a lot from him in last 15 years. I'm in regular touch with him. I'm very close to him. My practice is just 80 kilometers away from his place, my practice place. And then Dr. Bakul Parikh, the dynamic visionary president of Central IIP, who has invented digital IIP, DIIP, and through this only all the digital platforms, the gate of all the digital platforms opened, and all the Central IIP members are benefiting out of that. And now this MahaIP, the digital platform of MahaIP is also in line with the DIP only. So under the presidency of Dr. Ram Gopal Chezara sir and scientific convener Dr. Bhavish Mithya sir, we have started this top academics tips in office practice, and Sanjeev Joshi sir is coordinating this program very well. I welcome all the distinguished members of Maharashtra IIP, EB, Central IIP, EB, Dr. Jitendra Gawane sir, and all the delegates and PG students for this webinar. And I also request at this point Dr. Jitendra Gawane sir to say few words about this program to all the delegates. Jitu sir, please.
Yeah. Thank you, Amol. It is a great initiative by Maharashtra IIP under leadership of Dr. Ram Gopal Chejra and Amol Pawar sir
बाकीचे
to
सगळे
bring the pediatricians working in periphery, the various topics and the latest development in the topics so that they are very well versed with the upcoming updates about different modalities of treatment of common conditions. One of the common conditions in monsoon is snake bite and scorpion sting, and unless we have managed it at our own, it will definitely will not we will not be comfortable in managing it. So today none other than Dr. Sanjay Joshi sir from Dhule will enlighten about this, and as Amol said, Bakul Parekh sir will join shortly. So without wasting any time, I request Dr. Amol to start the program. Thank you.
Over to you, Dr. Satish sir.
Thanks. Thank you, sir. Thank you. Thank you and welcome to Dr. Jiten sir. I request Dr. Sanjay Joshi sir to say a few words about this program. He is a coordinator of this program.
Very rainy evening to all. My place is raining almost for the last 3 days, non-stop. Very pleasant weather. Actually, for the last 2 months, I was trying to catch hold of these two eminent stalwarts, those who are the faculties on today's this virtual platform of Maharashtra IP, Dr. Bakul sir and my elder brother, Dr. Sanjay. When Dr. Sanjay's name came to my mind, the only topic which I had imagined was the bites and sting, because he is the master for this stuff. So a strong academician, sportsman himself, very enthusiastic person. So I am extremely thankful on behalf of entire MahaIP team uh, for accepting our invitee, Dr. Sanjay Joshi and respected Bakul Parekh sir. Bakul Parekh sir doesn't need any introduction. A very dynamic and a very strong academician from Mumbai, past president of Central IIP, organizing chairperson of the IPA. He will be talking about a very useful topic, how to learn the approach when your symptoms are unusual in office practice. And extremely thankful to the to President Dr. Shejarap, Secretary Dr. Amol, and of course our young, dynamic, cheerful moderator of today's evening, Dr. Satish, ever smiling person, for accepting today's moderatorship. So I request Satish to start the proceeding, and I welcome all the virtual attendees, including our EB Central IP, Dr. Jitendra. Thank you all for attending this very informative webinar.
सतीश सर.
Satish.
सर संजय जोशी सरांचा पण आवाज.
Hello.
Hello, Satish sir, are you there?
Satish, mute झाला का?
Hello. सर संजय जोशी सरांचा पण व्हॉइस कनेक्टेड नाहीये.
संजय जोशी सर अनम्यूट करा.
No, his voice is not connected, sir. Sanjay Joshi sir. There must be some issue with his Zoom connectivity.
Joshi sir, you can start the session.
Sir, Joshi sir's audio is not connected.
Sorry,
Someone
sir.
has to call him.
Hello. I joined with the mobile. Sorry.
Yeah.
This there is a lot of raining here, so I could not connect. Connection is poor here.
Sir?
जोशी सर तुम्ही जरा सरांना कॉल करून सांगा ना जरा परत कनेक्ट व्हायला.
झालं कनेक्ट झालं तर.
त्यांचा ऑडिओ कनेक्ट होत नाहीये.
Okay. मी करतो फोन.
Sanjay Joshi sir's audio is not connected. Please ask him to
Yes.
rejoin again.
Yeah.
Thank you.
कनेक्शन बघा काय चालू होत नाही. ते बंद करून परत चालू करा. लगेच करू ना. तेच
Joshi sir? Joshi sir, are you there? Can you hear us? Sanjay Joshi sir? Amol sir, you are on mute. You are on mute, Amol sir. Yes. Yes.
बट जोशी सर का ऑडियो नहीं आ रहा है.
Joshi sir, we cannot hear you, sir.
अमोल अनम्यूट. अमोल अनम्यूट.
व्हॉट्सअप
Amol sir. संजय सर सगळ्यांना परमिशन दिली अनम्यूट करायची. अमोल सर, यू आर ऑन म्यूट.
अनम्यूट.
संजय जोशी सरांना अनम्यूट करा ना जरा.
हा केलंय सर. अनम्यूट केलंय बट वी कॅनॉट हिअर हिम.
कोणाला?
सर संजय सरांचा आवाज
अमोल
येत नाही
जरा
सर.
हा झाला ना, स्क्रीन झाला
मी
शेअर.
संजय सरांना फोन करतो. संजय जोशी
मी
sir.
केला
सरांना.
फोन त्यांना, ते त्यांचा ऑडिओचा काय प्रॉब्लेम माहित नाही सर.
आपले जसे का
त्यांना लॉग आउट होऊन परत लॉग इन करावं लागेल.
हॅलो.
येस.
सतीश सर तुमचा आवाज येतोय.
ओके, आता येतो ना आवाज. इथे सडनली
तुमचा
पूर्ण
येतोय सर.
सतीश सर.
संजय जोशी सरांचा आवाज नाही येते.
हॅलो सतीश
हा
सर.
येस. हा
हा पल्लव मॅडम, मी त्यांना सांगितलं की 1 मिनिट ते ट्राय करतायत आणि जर त्यांच्याकडनं झालं नाही तर ते मोबाईलवरनं जॉईन होतील, मोबाईलचा ऑडिओ ऑन ठेवतील आणि इकडं त्यांच्या टॅबवरनं ते स्लाइड्स बघतील आणि प्रेझेंटेशन देतील आपल्याला.
ओके सर,
ओके.
डन.
येस.
1-1.5 मिनिटं 2 मिनिटं वाट बघू.
नक्कीच सर, नक्कीच. ओके, थँक्यू.
तो पण इंट्रोड्यूस करून घेऊ का मी बाकी?
हो
संजय
सर,
जोशी
सतीश
सर.
सर तुम्ही इंट्रोड्यूस करा सर.
जोशी सर. सर मोबाईलवरनं जॉईन व्हा ना संजय जोशी सर.
सर मोबाईलवरनं जॉईन येते.
मोबाईलवरनं पण आहेत का?
हो, मोबाईलवरनं पण जॉईन येते आणि दोन्ही ऑडिओ ऑन आहेत त्यांचे. सर काइंडली म्यूट युअर लॅपटॉप ऑडिओ अँड ट्राय टू स्पीक फ्रॉम मोबाईल. संजय जोशी सर,
जोशी सर.
कॅन यू हिअर अस?
हॅलो.
हा आवाज येतोय सर, आता बोला.
आता येतोय?
हा
चालेल.
बोला, आता आता चालू करा.
करू चालू?
एक 2 मिनिटं इंट्रोड्यूस करतो सर.
एक मिनिट इंट्रोड्यूस करतील आणि मग
हो.
चालू करा.
स्क्रीन शेअर करतो फक्त.
थांबा थांबा थांबा.
बरं ठीक आहे ठीक आहे.
सतीश सर प्लीज कंटिन्यू.
Yes. Good evening, all. Sorry for the disruptions. So we'll be having a wonderful session ahead with stalwart Dr. Sanjay Joshi, senior pediatrician from Dhule. And sir has, like, when I saw his CV, it was wonderful to read also, because he's a professor of pediatrics in ACPA Medical College in last 25 years. And most importantly, he's got a very dynamic, I would say, kind of a CV where he visited 70 countries across the world. That is very important. He I was assistant in one first cochlear implant in Dhule in North Maharashtra. That is one of the, I would say, kind of a initiative what he has taken. He is a wonderful speaker in many conferences also. And I request sir to start with the session.
Thank you, sir. Just a minute. This time?
Yes, yes. It is starting. Yes.
Good evening, friends. Our honorary past president, Dr. Bakul Parikh, sir. Then the moderator of this session, Dr. Satish Shahane, sir. President of MAIP, Dr. Ram Gopal, sir. Our dynamic, enthusiastic, ever smiling secretary, like my younger brother, Dr. Amol, Dr. Mohan Warke, Dr. Mithia, sir. And our EB president, Maza Adna Bandhu, Sanju Joshi, sir, from Yavatma, and all my friends. At the onset, I extend my sincere thanks to my family of IIP, and because they have given me such a topic which is very close to my heart, and which I'm working in my medical college since last around 30 years on the same topic. I like this topic because it is one of the most common life-threatening and but the neglected issue of snakebite, because it poses a very significant health risk in children. Because there are 3 reasons. One is that the child's body is very small, but proportionally there is a larger surface area, and therefore they are more prone to get the side effects of poison very fast. Children explore many areas like bushes, the playgrounds, and upper plants and outdoor plants. And there's a high degree of morbidity and mortality in children. Another thing is that this is a very perfect time to talk on this season, because in the monsoon season, there are maximum snake bites which occur. And snake bites are not restricted to the rural area, but also frequently seen in metro cities. And most important is the proper approach and prompt
Sir, I
treatment.
think you are logged out from the computer.
Sir,
We cannot see your screen.
Yeah, slide is not seen.
Sir, you are logged out from your PC.
Hello, sir.
Sir, slides are not seen.
Joshi sir, your
Slides.
slides are not visible. You have logged out from your PC.
Oh, just a minute. Right, sir.
जोशी सर,
हा बोला.
तुमचं पीपीटी पटकन व्हॉट्सअपला पाठवा. पल्लवी मॅडम इकडून शेअर करतील सर.
बर, एक मिनिट मी मेल करू का?
पुढे डिस्टर्बन्स येणार नाही. मग तुम्हाला फक्त बोलणं राहील आणि तुमच्या टॅबवर तुम्ही स्लाइड्स तुमच्या चेंज करू शकता.
मेल करू का? मेल
हा, मी ईमेल आयडी टाकतो, लगेच करा ईमेल.
लगेच करतो. मेल करू. कुठलं?
ईमेल आयडी टाकला मी.
एक सेकंद. अमोल पवार, AMOL अमोल पवार 98@gmail.com.
पल्लवी मॅडम, तुम्हाला जमेल का शेअर करायला, का सतीश सरांना सांगू?
सर करते मी शेअर करते मी.
ओके, थँक्यू.
काय म्हणताय सर?
98 अमोल पवार 98 आणि इथं घ्या.
कॉपी करून पेस्ट करा सर तिकडे डायरेक्ट.
gmail.
सर एक ईमेल आयडी अजून सांगू का तुम्हाला?
हो सांगा सांगा.
सर तुम्हाला कंटेंट मध्ये पाठवलाय चॅट मध्ये.
चॅट मध्ये
अमोल सर तुम्ही पाठवण्यापेक्षा मी डाउनलोड करून घेते.
हो सर, मी पण व्हॉट्सअपला टाकलाय पल्लव मॅडमांचा ईमेल आयडी.
एक मिनिट.
इकडून कॉपी करून पेस्ट केला तरी चालेल. येस,
कॉन्टॅक्ट ऍट
तुम्हाला व्हॉट्सअपला टाकलाय.
सीसी मध्ये कॉन्टॅक्ट ऍट XPO SURE Infotech INFO TECH @.com नुसतं .com. अमोल पाठवलंय.
नाही, अजून नाही आलेलं.
अरे व्हॉट अमोल पल्लवी मॅडमच्या व्हॉट्सअपवर घे ना. व्हॉट्सअपवरनं त्या हे करतील,
हो
स्क्रोल
सर.
करतील.
सर ईमेलला पाठवतायत. मी व्हॉट्सअपलाच विचारलं होतं.
व्हॉट्सअपला कसं काय पाठवते?
आलंय. पल्लवी मॅडम आलंय.
आलं ठीक.
येस,
परत एकदा
आलंय सर. तुमच्या टॅब मध्ये तुम्हाला स्लाइड दिसतील सर, आणि मोबाईलच्या ऑडिओने तुम्ही बोलू शकाल सर.
ओके.
पल्लवी मॅडम केलं का डाउनलोड? पल्लवी मॅडम
सर डाउनलोड करते, एकच मिनिट द्या.
येस. ओके. येस डन. जोशी सर 1 मिनिटात चालू
अमोल.
होईल सर्व.
हो.
येस.
अमोल,
येस
बकुल सर जॉईन झालेले आहेत.
हो. वेलकम डॉक्टर बकुल पारेख सर.
घ्यायचं का
वेलकम
आधी?
सर.
वेलकम सर.
सर देखिए
बकुल सरांचं मग
जोशी सर थांबा जरा. संजीव जोशी सर थोडं थांबा जरा.
हे डॉक्टर बकुल
बरोबर.
दुसरे आहे. हा, आता आले सर.
वेलकम
पल्लवी
सर.
मॅडम झालं का?
येस जोशी सर, वी कॅन सी हिम नाउ.
सर 77 हे आहेत, त्यामुळे डाउनलोडिंगला वेळ घेतोय थोडा.
ओके. बकुल सर वेलकम सर.
अनम्यूट सर.
पल्लवी मॅडम बकुल सर ना हे करा ना.
हा हॅलो.
हो
आता
सर,
अनम्यूट केला.
एक मिनिट
होस्ट
सर.
मला अनम्यूट करत नव्हता. मला अलाउड नाही की काय?
किसकी हिम्मत है आपकी बोलती बंद करने की सर?
वेलकम सर.
वेलकम
थँक्यू
सर.
राम गोपाल. थँक्यू अमोल, सतीश, संजीव. या
जोशी सर, वी कॅन स्टार्ट.
Can I start now?
यस सर, नाउ वी कैन हियर यू क्लियरली.
वेट. राम सर वेट.
अरे तब तक सर अपना स्लाइड चालू कर देंगे ना. नाउ ये
सर डाउनलोड नहीं होते.
अरे डाउनलोड हो रहा है
होते
राम भाई,
presentation.
रुको जरा.
सर प्रेझेंटेशन डाउनलोड नाही होते.
संजय सर, तुमच्या
हा.
लॅपटॉप तुमच्या टॅबवर तुम्ही स्लाइड बघू शकाल. आणि तुम्ही आता मला वाटतं मोबाईलवर न बोलतायत ना?
हो, मी मोबाईलवर बोलतोय.
हा बरोबर बरोबर. म्हणजे इकडून स्लाइड बघाल आणि तिकडून हे करा.
नाही
सर डाउनलोड नाही होते त्यांचं प्रेझेंटेशन.
सर तुम्ही कॅन यू स्टार्ट युअर स्क्रीन अगेन शेअरिंग, विल जस्ट चेक.
अमोल सर त्यांचं ना हे पीपीटी डाउनलोडच नाही होते.
बापरे.
सर तुम्ही चालू करा ना तुमच्या टॅबला.
एक मिनिट. एक काम कर, बॅग आता दिसतंय?
आता दिसतो. येस सर.
करू सुरू?
येस सर.
स्लाइड बदलून बघा ना सर.
येस सर. डेफिनेटली
येस येस. मॅडम माझ्या मोबाईल मध्ये ओपन झाले आहेत.
सर आता झालं माझ्याकडे पण डाउनलोडिंग.
चालू करा आता.
एक मिनिट ऐका जोशी सर.
हा बोला ना.
तुम्ही तुमच्या इथनं बंद करा, पल्लवी मॅडम शेअर करतील.
बरं ठीक आहे चालेल.
तुम्ही तुमच्या इथून बंद करा. येस
हो चालेल.
म्हणजे मध्ये एकदम आता फ्लुएन्सी पाहिजे आपल्याला.
हो चालेल. काय बोलते?
अजून एक मिनिट लागेल डाउनलोड व्हायला.
हॅलो
संजीव जोशी सर. म्यूट करा म्यूट.
सर 1 मिनिट दाखवतोय अजून तो डाउनलोडिंग कम्प्लीट. मी इमिजिएटली शेअर करते.
मी व्हॉट्सअपला टाकलंय बघा तुम्हाला.
हो सर हो. डाउनलोडिंग झालंय ऑलरेडी ऑलमोस्ट.
काय म्यूट झालं? नाही.
काही लोकांना दिसते, काही लोकांना दिसत नाही आहे.
पल्लवी मॅडम. पल्लवी मॅम.
सर प्लीज स्टार्ट. कॅन यू सी माय स्क्रीन?
येस.
ओके सर. सर प्लीज स्टार्ट.
येस.
कॅन आय स्टार्ट?
हा तुम्ही फक्त स्लाइड चेंज करायची ऑर्डर द्याल मॅडमला. मॅडम चेंज करतील नेक्स्ट म्हटलं.
मी नेक्स्ट
सर प्लीज स्टार्ट.
So good evening friends. Our honorary past president Dr. Bakul Parikh sir, my mentor. I always have a great respect for him. The moderator of this session, Dr. Satish Sahane sir. The president of MahaIP, Dr. Ram Gopal sir. Our dynamic, enthusiastic secretary, Dr. Amol. Dr. Mohan Warke, Dr. Mithia. Our EB member, Dr. Sanjay Joshi sir. And friends. I extend at the onset, I extend my sincere thanks to all my IIP family for giving me this opportunity. This topic is very close to me because I'm working on this topic for last so many years. This is a very perfect time because the monsoon is the season where we see maximum snake bites. Snake bites are most important is not restricted to the rural area, but even in metro cities, snake bites are seen. And a proper approach and a proper prompt treatment can prevent a lot of morbidity and mortality. Children are especially more prone for the problems of snakebite because they've got small body size and proportionately larger surface area, and therefore the problem of poison is more in them, and they've got a high degree of morbidity and mortality also. So I'm going to talk very practically. I'm going to present two cases which actually come to our OPD in our day-to-day practice. So let us see the first case. This was a 6-year-old Rahul who was rushed to the OPD with history of snake bite while playing in the park of the society. The parents were so angry that they killed the snake and brought the child to the OPD. The worried parents had applied a tourniquet also. On examination, the child was frightened. He was sweating. He was febrile. The pulse was 112 per minute. BP was 98/64. His respiratory rate was 30. He was conscious. Pupils were normal. There was no ptosis at this point. There was a pain at the site of bite, and there was no active bleeding. And local examination showed that the tourniquet was seen, the fang mark was seen. There was no local bleed. There was just mild edema. So this was the child who presented to in actually our clinic pediatric OPD in the evening. Next. So the first question, the parents are very anxious. The first question they ask me that, doctor, we live in a very posh society, gated community, and how can the snakes come there? So I told him that the snakes are ubiquitous, and then when I searched all over all the literature, next, I found, next, madam, that snakes are seen in all metro cities. They are seen in Pune, they are seen in Mumbai, they are seen in Nagpur, and to the tune Nasik, Dhule, everywhere. And to the tune that when I read, I went to the literature, I found that the snakes are more commonly seen in Melbourne and even in New York. So snakes are ubiquitous. So it's not that many of my friends think that अरे हमारे यहाँ तो कुछ snake bite दिखता नहीं है. I tell you that snakes are seen everywhere. Next, madam. If you see the global magnitude of the problem, around 12 to 55 lakhs of snake bites occur in all over the world, and around 4.2 lakhs envenoming occurs because 80% are dry bite. Now, this concept is very important, that there is something called a dry bite. Even if the snake bites you, there are many reasons that it may venom into your body. This is called a dry bite. 80% of the cases, it is a dry bite. And there are so many causes of dry bite, like the gland of the snake is infected, or even if the snake has bitten to you from your clothes, and so many things. So remember, when we counsel, I'm going to tell you how do we counsel. The first thing we tell the patient and the parent that this could be a dry bite also, so don't worry about it. Approximately out of these, around 81,000 to 1,38,000 death occur, and 3 to 4 lakh suffer from disability. The most important thing is that WHO, no, madam, previous one. Yeah, the WHO has passed a resolution that snake bite is a global health priority, and WHO has added that snake bite is to the list of neglected tropical disease and given a global action plan. The important thing for us is that India is reported to have maximum snake bite all over the world, and even the deaths are also. Next. If you see this geographical picture, then you will find that the dark area is India, and it shows that more than 1 lakh envenoming every year in our country. So common in Asia and South Asia, but India more than 1 lakh envenoming occurs, and around 11,000 to 14,000 deaths occur every year. And out of that, 20% of them are children. So much high mortality is seen in children. Next. No, the most important second question the parent asks you when they come into the OPD, doctor, is this poisonous bite or non-poisonous bite? They are very, very anxious, and they ask us the question that is poisonous bite or non-poisonous. And we must know how can we differentiate between poisonous and non-poisonous snakes. Next. So can you differentiate between poisonous and non-poisonous snakes? Yes. Next. Now, if unfortunately, ideally, it is said that snake should not be killed. One should never run after the snake. First thing and most important thing. Previous, madam, previous one. The most important is you should not kill the snake. You should not run after the snake. This is told everywhere. But in spite of that, the parents are so angry and anxious that they kill the snake. So if the snake is brought in killed snake is brought in your OPD, then just remember the 4 important things. That the first one is a cobra, that is also called a nag in our Marathi language. Then another is called as common crate, which is called as manyar. Then comes the Russell's viper, which is called as ghonas. And then the salt-scaled viper comes at Taurea ghonas, and then called as banded crate, that is pateri manyar. So these are the one which you can obviously see. But the most important next important is that non-poisonous snake. So if you see that the snake is thin, a long one, and there are various differentiating features which I'm going to tell you, then you can tell the parent that this is a non-poisonous snake and don't worry about that. Next, madam. So there are a few points which you can distinguish from observing a snake. If you see the ventral part of the snake, if there are double rows of scales like this, then it is usually a non-poisonous snake. And if it's a single line of scales, then it is a poisonous snake. Always remember, if the skin, the body of the snake is thin, it is usually a non-poisonous snake. But if it is a very thick one, it is a poisonous snake. Then you can see the snout. If the snout is pointed, it is poisonous. If it is rounded, it is non-poisonous snake. But the point from our clinical point of view is that the fangs. These are the fang marks that you can see. Next, madam. So clinically, if the child comes to you with this upper type of only two snake fang mark, this is mostly venomous snake or poisonous snake. So when you observe the local site and you find that there is edema, but there are only two bite marks or fang marks, then it is usually a poisonous snake. And like the lower picture. Wait, madam. The previous one. So, like the lower picture, if there are multiple points are seen of biting, then it is usually a non-venomous snake. So, from examining the patient, we can differentiate whether it is a poisonous snake or a non-poisonous snake, and tell to the parents. Next. Medically important, there are 5 important species of snakes which are seen in all over India. The most important is there are big four, that is cobra or king cobra, then common krait, they are from Elapidae family, and then Russell's viper and saw-scaled viper is Viperidae family. Now, there is a very important thing to remember here. There are two important poisonous snakes which are seen in Western Ghats. Like आपल्या कोकणामध्ये फार असतं. Hump nose pit viper, that is one, and Sochurex saw-scaled viper, which is seen in North India. Now, the important point to know is that the ASV which is available with us by Government of India contains the poison antidote against 4 important ones. That is cobra, common krait, Russell's viper, and saw-scaled viper. It doesn't include the antidote against hump nose pit viper and Sochurex viper, and therefore it is a time to change the ASV, that we should, as our academy, we should tell the government that they should include all 6 of them, so that it will be covering more of the snakes. Next. Now, what are the clinical signs and symptoms? So, suppose there's a patient of snake bite comes, and as I told you that the parents are very anxious, and they bring the child to your table and say, "Doctor, isko snake bite ho gaya." So, what will you clinically see? Next. The clinical signs can be classified into 5 things. First is the fang mark. As I told you, the fang marks are very important. That if there are 2 fang marks, it is poisonous. There are multiple fang marks, it is a non-poisonous one. Then the second group is the local one. Remember, pain is a very common thing, but crate bite is a painless bite. It is very important. Many times the patient comes to, "Kai doctor, काही झालेलं नाही, थोडंसं काहीतरी चावलंय, maybe काही नाही असेल." But if you are sure that if it is a snake bite, it is better to keep the patient under observation. So, because crate bite are painless, all other bites are painful. You can get swelling, ecchymosis, bleeding from the local site, or a serosanguinous discharge. Then group 3 is a local or systemic envenoming effects like fever, headache, muscle cramps, then ptosis. Sometimes there's a bleeding tendency, and then there's a neuroparalytic shock. Then there are 4 signs of extreme anxiety. There's numbness, tachycardia, pallor. The most important thing is that the patient becomes so anxious, and he always feels that I am going to die. And this feeling makes him more and more anxious. Tachycardia, it increases the tachycardia, the pallor, the vomiting, loose motions, tachycardia, sweating, and sometimes vasovagal shock also, just by the feeling of snake bite. So this is the 4th group, and last group is the signs related to the first aid treatment, like usually tourniquet. Though it is advocated that tourniquet should not be tied to the patient, still now many educated patients come with a tied tourniquet. Next. And this is just a diagrammatic representation of signs and symptoms. Next. Commonly, all 4 can be classified as cobra is usually neuroparalytic snake. Always remember. It causes ptosis, diplopia, then respiratory paralysis, low hypotension, and the patient ultimately goes into unconscious state and cardiorespiratory arrest. Common krait again is a neuroparalytic symptom, but I told you that there are no local signs. So that's the way we distinguish between cobra and common krait. Cobra has multiple local signs. There is a fang mark, there is a edema, there are blebs, there is bleeding from the local site. While common krait, there are no local signs. Otherwise, the patient has same, that is ptosis, diplopia, dysphagia, respiratory paralysis, hypotension, and ultimately goes into unconscious state and cardiorespiratory arrest. Next. While the two other vipers, previous one, previous one, previous one, previous one, madam. While the two other, like it's next one, madam. So two other one, that is Russell's viper and Soskell viper, are usually hemotoxic and nephrotoxic. Among them, Russell's viper is a nephrotoxic snake. Always remember that it is a dictum that I'm going to tell you, that every patient of snake bite should be admitted for at least 48 to 72 hours, because Russell's viper may not have some local signs, but they usually present in acute kidney injury, and they present with hematuria after 48 to 72 hours. So Russell's viper is responsible for kidney injury. They can cause, and even that is hemolytic problems like pain, ecchymosis, bleeding, necrosis, mouth, GI bleeding. So this is all Russell's viper, while Soskell viper is mainly the related to the hemolytic one. So how this is a very simple. Wait, madam. Wait, madam. Next one. Yeah, this is very simple flow chart to diagnose which type of snake it is. So if it is an unknown snake bite, the patient comes to you and say, "Ki doctor, fakta saap chavlela hai," and you don't know anything about the snake has not been brought, then the important thing is you observe the local swelling. If there's a minor local swelling and no venomous side effect, no effects, then it is usually a non-poisonous snake. But if there are neurotoxic signs, then it can be either cobra or crate. If there are neurotoxic signs with local swelling, then it is usually cobra. If it is neurotoxin signs without local signs, then it is usually crate. Hematotoxic manifestations, if it is only hematotoxic, it is usually Russell's viper or Soskell viper. But if it is hematotoxic and renal failure, it is usually Russell's viper. So this is the way we usually classify whether the patient is bitten by which type of snake. These snakes are myotoxic. Next. So this is the type of blebs or bully that we get in many patients, and this is an ecchymotic patches and edema which is seen. Remember, usually blebs and more local signs are seen with the cobra bite, while less are seen with non-poisonous and crate one. Next. Next. Okay, so the dictum is all patients of snake bite must be admitted to the hospital, because I told you there are two important things. Many times the Russell's viper can cause nephrotoxicity, and then they can present late also, while many patients have late manifestations. Therefore, dictum is every patient of snake bite must be admitted for 72 to 48 to 72 hours. So coming back to our patient, Rahul was admitted because as he had there were definite history of snake bite, so he was admitted in the hospital. Next. The ptosis. Ptosis is a very early sign, and you can identify that the patient is going into neuroparalytic manifestations after observing ptosis. And this is the worst thing which everybody must remember, that never and never tell that no tourniquet should be applied. Tourniquet is the worst thing. It is not advocated. Many people still, there are some people say that a light tourniquet should be applied to prevent the lymphatic spread, but no tourniquet is applied, because that causes the compromising. There are many complications of the tourniquet rather than of snake bites. Next. This is a Cephalon score. Whenever the patient is admitted, suppose the patient is admitted in the hospital with snake bite, then we go for the snake bite scoring system called a Cephalon score, which includes all the system like pulmonary system, the cardiovascular system, the local wounds, the gastrointestinal system, hematological manifestations, CNS manifestations, and this is available everywhere. These are the printed charts which we have done in our ICU also in pediatric ward. So they have given number 0, 1, 2, 1, 2, 3, 4 like marking or scoring, and then at the end of that, the score is that if suppose it is more than say around 20, then it is a poisonous snake, and we need some immediate action. So this is a Cephalon score which is seen in every patient of snake bite. Next. Now comes to the management. Management guidelines are given by the WHO. They are very standardized, and it is everywhere, most of the places. It is the WHO guidelines which are followed. Next. Next. First one. First. Well, before that. So management consists of three important things. Next, madam. Management consists of three important things: the first aid, the immediate management, and the specific management. Next. The international snakebite protocol is called as the right protocol, that is RIGHT, which says for first aid. This is for first aid. They say that the first important thing is you must reassure and relieve the anxiety. As I told you, anxiety causes tachycardia. Tachycardia increases the rate of circulation and the spread of poison, and therefore we must tell the parents and the patient also. The patient, the younger patient or the pubertal patient are very anxious. They always feel that I'm going to die. I'm going to die. So tell them that no, this could be a dry bite, this could be a non-poisonous snake. So don't worry, you are 100% going to survive. Nothing will happen to you. So first, relieve the anxiety, give a reassurance. Now, second important thing is immobilize the limb like a fracture. This is very important. Even if you are in your clinic and the patient has come to you, the first important thing is like you apply a splint. The previous one, madam. Previous one. Adichit. So like you apply a splint in an IV fluid, giving IV fluid, immobilize the limb like a fracture. So just immobilize the limb. Go get the patient to the hospital. So hospitalization is missed, and tell the toxic signs to the doctor. So ptosis and everything all should be told to the concerned doctors. Next. So most important thing in first aid is first that we have seen allay the anxiety, because almost 2/3 of the bites are non-venomous and 80% of dry bites. And anxiety can itself cause hypotension, increase excitement, increases the heart rate, and can spread the poison. Remove the shoes, remove the clothes, watches, rings, everything. Now, the important thing here is that as we always compare snake bite with a dog bite. So what we do is we wash the wound in dog bite. But remember, in snake bite, just pour the water, clean the wound only with sterile saline, and don't wash. Never wash. If you wash it, it causes spread of the poison. So washing is not at all allowed in snake poisoning. And as I've told you that immobilize the limb like you do in a fracture. Place the affected part below the level of heart. This is again important. The patient is lying, then the heart, the affected part should be kept below the level of the heart, and arrange to shift to as far as possible in ICU. If possible, get a photo on the mobile and send to the consult doctors. All patients must be admitted for 24 to 72 hours, because I told you that late onset symptoms are well documented in hyperbite, and they usually present in kidney injury after 72 hours. So all of them must be admitted for 24 to 72 hours. Now, investigations, the common investigation, most of the time the diagnosis is a clinical one, but there is a test called a WBCT test, that is a bedside test. This is especially more important for hematological manifestations. So this is a very simple test which I'm going to tell you, but you can have other coagulation disturbances. Therefore, PTTK is raised, then phosphokinase are raised, then you can get fibrin degradation products, then PTCT is prolonged. D-dimer is another investigations. One can go for myoglobin studies. There are newer investigations like antibodies for the snakes are detected by various technologies. The renal function test must be done to rule out acute kidney injury. Wait, madam. Wait, madam. Wait, madam. So renal function tests are very important to rule out the acute kidney injury. Urine shows hemoglobin urea. You can do immunodiagnosis by doing ELISA or radioimmunoassay, and of course XRHS can be done and ECG can be done. Next. This is a very simple test called as 20-minute whole blood clotting test. The method is very simple. Just withdraw around 4 to 5 ml of blood. Take in a small bottle, or you can take even 2 ml of blood. Take in a small bottle. Keep it for 20 minutes and just try to move it. If it is clotted, that means the test is negative. That means the clotting is good. That means it is not a hematotoxic snake. But if it is still flowing, the blood is still flowing even after 20 minutes, then the test is positive. That it means that it could be a hematotoxic manifestations. Next.
Sir, sorry to disturb. May I ask a question, please?
Yeah.
Sir, the slide is showing 20 minutes whole blood clotting test. So
Yes.
this the sample bottle which we can see on picture number 3. So does it contain any previous solution, or it's a
No,
plain bottle?
no, it's a plain
plain
bottle.
bottle.
It's a plain
Okay.
bottle. You have to take 2 ml of blood in that, and you have to keep
Okay.
it just like on figure number 4. You don't have to move also. Just keep it
Okay.
there.
Okay.
Just keep it
Okay.
there, and after 20 minutes, you try to move it. If it is
Right.
flowing at the end of 6 minutes, 20 minutes, then like in the figure 6, then it is flowing. That means the test is positive. That means the patient has some hematological manifestations. And if
Okay,
the
sir.
patient, if the like in picture number 5, if it is clotted, that means the test is negative.
Okay,
This
sir.
is a
Okay.
very
Thank you so
simple
much.
bedside test, so most of the sisters also can do it.
Okay.
Next.
Thank you so much, sir. Thank you.
Next.
Delegate, you can actually put the question in chat box also. We'll take it
Yeah.
at the end of the session.
So this is the most important slide. Do's and don'ts in the first aid. The don't incise and wash the soap. Now again the same thing, like I told you that in dog bite, we ask the patient to do a soap wash with the soap, a lot of water, everything or saline. Now in snake bite, we should not wash because washing causes spread of the poison. Then do not suck, like we see in many Hindi pictures, but do not suck, do not cauterize, do not cryo the wound, do not infiltrate ASV around the bite mark. So this is another thing which is different from our snake bite, the dog bite. Do not apply local ointment. No drinks or alcohol should be taken. Do not catch the. This is very important. Even the educated patient we see in our OPD, many times they bring a snake which is killed by them. So असे पिशवी बाहेर काढतात आणि त्यातनं तो साप बाहेर काढतात. This is not allowed. Even the animal lovers can take you to the court of law. So you should not. And you always tell your patient not to kill the snake because it also takes a lot of time. Wastage of time is there. Do not apply tourniquet. Never. Do not burn the wound, do not use snake stones, etc. So what is the previous one? Next one. So what is the immediate treatment? Once the patient is admitted in the ward, for the first thing we do clinical assessment, as we have seen, Cephalon score, and then we establish an IV line. Urgent resuscitation, like our ABC, airway, breathing, circulation is in. If the patient has got hypotension, we treat the hypotension. Oxygen is for asphyxiated patient. Treat all allergic reactions and angioneuremia or bronchospasm. Many patients develop bronchospasm. This is very common. This is either due to the bite also, or if the patient becomes very anxious, he gets a bronchospasm. So you must treat the bronchospasm. Give tetanus toxoid injection. It is another important thing. Broad spectrum antibiotics with anaerobic coverage should be done. Paracetamol as an analgesic. We should avoid aspirin. Previous slide. Previous slide. So you should avoid aspirin, nimesulide, and mefenamic acid. Vomiting is very common because of vasovagal symptoms, and therefore you must treat vomiting and you must take the care of the wound. Next. Now, specific treatment, ASV. There are two types of ASVs. There is species-specific monovalent antivenom and total specific, that is polyvalent antivenom. I'll talk about polyvalent antivenom. The point here is that the important point to remember is that this total specific antivenom contains antivenom antibodies or dose against 4 important snakes like cobra, crate, Russell's viper, and soft-scaled viper. Now the problem is that suppose there is a child who staying like we are seeing many children from Adivasi area. Suppose the child is brought to you with cobra bite and you give the polyvalent antivenom. The child recovers, and after 2 years, if the child get again bite, and now the bite is by crate, then if you get the same polyvalent vaccine, then it is of no use because the child has already developed antibodies to this, and therefore the child get resistant to the ASV. And this is the main important thing of getting a monovalent antivenom. Now the problem with monovalent antivenom is that availability is very difficult, first thing. And the most important thing, if the bite is, we really don't know because we don't promote that you kill the snake and bring the snake. So if the parents have not identified the snake, then it's very difficult that which type of snake it is. So at present, we only use polyvalent antivenom. Next. So species specific, as I told you, that antivenom problem is non-availability, high cost, and difficult identification. But the important advantage is that reduced cross-reactivity. But the total specific polyvalent antivenom, which contains antibody against all 4, that is cobra, Marathi त्याला आपण नाग म्हणतो, common crate, मण्यार, Russell's viper, Gonus, and soft-scale viper, Tauria gonus. So these are the four important ones which is covered by the total specific antivenom. Next. Now, what are the indications of ASV? As I told you that many of the bites are non-poisonous and 80% of dry bites. So in which condition you will select ASV? The patient is there, patient is admitted in your ward. So when the resident asks you, sir, doctor, sir, ASV द्यायचं का? So what are the things? The important point is that the first local manifestations, extensive swelling, blistering, as I showed you, then bruising of the limbs, rapidly increasing swelling, affected becomes, and even sometimes you can palpate the nodes very fast. So in that situation, if the local manifestations are there, like systemic manifestations like hemostatic disturbances, like bleeding, shock, hypotension, pulmonary edema, then impaired consciousness, ptosis, or renal function tests are abnormal, like acute kidney injury or hemoglobin urea, or there are lab manifestations which are abnormal like 20 BCT or PTTK is prolonged or renal failure like that. Now comes the what is the role of antivenom and what is the dose and what do you do if the child gets an anaphylaxis? This is a very common thing. If you come across the snake bite patient, you give an ASV and the patient goes into anaphylaxis. The first important thing is wait, madam, wait. The previous slide. Next one. So what is the dose? Remember, the dose of antivenom is same for adults and in children. This is very important thing. Like all other conditions, we do not reduce the dose. If there is no envenomation, there are no local signs, then we just wait and watch. If there's a mild envenomation, that is fang marks are seen, there's moderate pain, there is minimal local edema, erythema, ecchymosis, then we give 5 vials. If it is moderate envenomation, that along with fang marks, there are moderate edema, then there are some ecchymosis, then sweating, syncope, or nausea, vomiting, thrombocytopenia. Then we give 5 to 10 vials. Severe envenomation, then fang marks with all other things like hypotension or pulmonary edema. Then we give 10 to 20 vials. Next, madam. The dose of ASV, snakes inject the same dose of venom in children and in adults, and therefore the dose of ASV is constant. Children must therefore be given exactly the same dose of antivenom as adults. How to inject? There are two methods, the push method and infusion method. You can either push directly or infuse directly. Very important thing, prior skin test is never advised. Never, remember, prior skin test is never advised because it wastes the time. Even if you waste half an hour and suppose the child gets some itching and everything, everybody's confused whether to give or not to give. So don't waste time. Directly give ASV. Either push method or infusion method. We practically in our institute give infusion method. Next. The repeat dose decision is taken after repeated assessment. Usually we give 2 to 4 vials given every 2 to 4 hourly, initially for 6 hours, then 2 vials every 6 hourly for 12 to 18 hours. A maximum dose is usually 20 vials. Now there are many studies that many times what happens is that you give 20 vials and the patient is still unconscious or the patient is on ventilator and somebody tempts that there is a temptation that should I give more vials? No, remember, many studies have suggested that adding more ASV will not be effective. So it's not effective. Maximum you give is 20 vials. Next, madam. So this is the ASV from Hafkin, which is available. You can get also from Serum Institute of India. Previous one. So each ml of ASV neutralizes 0.6 milligram of cobra venom, 0.40. Next one. 0.45 milligram of crate, then 0.6 milligram of Russell's viper, and 0.45 milligram of soft-scale viper. Next. So the important thing, as I told you, is anaphylaxis. I always tell my residents that be prepared for anaphylaxis. Consider that every patient is going to get anaphylaxis. So consider that, and then you will be prepared for anaphylaxis. There could be 3 types of reactions, either early reaction between 1 to 80 minutes, or a pyrogenic reaction which comes after 1 to 2 hours, or a late reaction which comes up to even 12 days. Approximately, they have given 3% to 81% patient can get anaphylaxis. So anybody can get anaphylaxis. One should be always prepared to face such emergencies. So we always keep everything ready, considering that every patient is going to get anaphylaxis. Anaphylaxis can be managed by, as you know, adrenaline, oxygen, IV fluid, hydrocortisone, antihistamines, everything. ASV should be stopped till the treatment of anaphylaxis. Most important, ASV must be restarted after the treatment of anaphylaxis is over. Once the patient settles down, ASV should be immediately given. So give ASV considering that every patient is going to get anaphylaxis, and stop for some time. Let the patient settle down. When the patient settle down, restart the ASV. Patient improves very dramatically within minutes or hours after giving ASV. Prior skin test, as I told you, is not recommended. Next. So our progress of the patient, unfortunately, Rahul developed neurotoxic manifestations. He had ptosis and leading to respiratory paralysis. So how do you assess the neurological deterioration? So this is a system scoring system called a National Neurological Scoring System. There are 5 important points. Single breath count, very very simple thing. त्याला श्वास घ्यायला लावायचा आणि त्याला आकडे म्हणायला लावायचे. And this we do immediately after coming the patient. When the patient comes in casualty, we ask him हा 1 ते 10 म्हण, किंवा तुला समजा युजली 1 ते 15 म्हण, वॉट एव्हर इट आहे. आणि आपल्याला अंदाज येतो की साधारणपणे 1 मिनिटामध्ये तो किती म्हणतो. अँड देन यू मेजर इट ग्रॅज्युअली. एव्हरी 15 मिनिट्स आस्क हिम टू काउंट इट. अँड देन when you come to know की त्याचं आता काउंटिंग कमी होत आहे, that indicates that he is going to develop a neuroparalysis. So single breath count, millimeters of iris covered by eyelids, though that is the indication of ptosis. Ptosis खाली झाल्यामुळे काय होतं की the eyelids are coming down, and therefore the millimeters of iris covered by eyelids is measured. That is the second thing. Then inter-incisor distance. So ask the patient to say ah, and when gradually every 10 minutes when you ask him to say ah, and when the distance between the incisors go on reducing, that means the child is going into wait. That means the child is going to neuroparalytic shock, neuroparalytic symptoms. So, and the last is the length of upward gaze palsy. So upward gaze can be maintained. So patient ला म्हणायचं की वरती बघ, and you measure तो किती वेळ वरती बघू शकतो. So within 10 minutes or 15 minutes, ask him to repeat the thing, and then you can measure the distance. And lastly, if you have there's no role of Glasgow Coma Scale. Next, madam. So unfortunately, Rahul went into he had neurotoxic manifestations. He was put on ventilator. He was given pharmacotherapy with cholinesterase like neostigmine. Before neostigmine, we have to give atropine. The starting dose is usually 0.5 milligram per kg, but afterward the dose is titrated as per the response. Some people go for tensilon test, but the details I can share you with them, not here. But many people, most of the institute do not go for tensilon test. That is the test before starting the actual treatment. You give one dose and see the response of the patient. Next. We give fresh, many times the patient is hematotoxic manifestation, then we give fresh blood or cryoprecipitates, especially in hematotoxic manifestation. Acute renal failure can be managed as per the protocol, especially as I told you, the scaled viper Russell's viper bite. ARDS and respiratory failure can be managed by ventilatory support. Viper bites are associated with capillary leak and can lead to hypotension and shock. So shock should be treated as per the protocol. Very, very important that we must report to the health authority. So you have to call the health authority, the DHO or the health authority, and tell them that I have got a patient of snake bite, and they come and register his name. So we actually come to know the exact amount of number of cases we see. Next. But what is the new horizon? What is the new horizon in snake bite? The problems was first important thing is availability of ASV. So many times, many places, आम्हाला पण असा problem येतो की snake bite चा patient येतो. We always keep some stock of snake bite, but many times the ASV is not available. So the problem is not availability of ASV. And another thing, anaphylaxis, and very important, as I told you, that cross reactivity that you give for cobra, and sometimes the patient comes next time with crate, and then you can't give it. So the new horizon is a cocktail of monoclonal immunoglobulins. That's a very important thing which is going to come. Monovalent immunoglobulins prepared by recombinant DNA technology. In India, Cobra antivenom is prepared by genome sequencing method technology. And the research for Netherlands have been created a venom producing gland by using stem cell technology. So a gland is created, and then you get a venom, and then you can develop an anti-snake. At present, you all know that it is an equine one. we did low doses of venoms are injected into the horses, and their serum is collected and then pulled and performing the ASV. Next.
Sir, we
Next.
have 5 minutes more.
Was 8 minutes, sir. I just one interesting case which we come across, very common. This is a very interesting thing. That EMNS, that is early morning neuronal sickness. Sickness. This was a 12-year-old female was brought to the emergency with unconscious stage at 6 o'clock in the morning. She was absolutely fine previous morning. Kais nahi, taap nahi, kai nahi, nothing else. And the only thing positive thing was they were staying in the farm and used to sleep in the open ground. Next. Next. So on examination, everything was normal. She was deeply unconscious, very sluggish respiration. Next. 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 Next, madam. Next. Next, madam. Madam, next. So this was the patient, there were no marks, and this is a very classical entity called EMNS. It's an early morning neuroparalytic shock. So the bottom line is that every patient, unconscious patient, comes in our territory without fever, without any clinical signs. This could be an early morning sickness. This is due to the bite of a crate bite due to previous in the previous night. These patients, even if there are no manifestations, snake bite, no fang marks are seen, we usually start with ASV and neostigmine, and most of the time we get good result. Next. Next. So this is the thing, just few things. आम्ही सगळ्यांना एकच सांगेल की you try to get a number of snake friend. जे सर्पमित्र असतात ना, त्यांचा एक नंबर घेऊन ठेवा. कारण मोस्ट ऑफ द टाइम्स आपण म्हणजे पेशंट तर जाऊ दे, आपल्या घरात जरी कुठून चोकून साप बी आढळला तर आपण इतके घाबरून जातो. तर एखादा सर्पमित्राचा नंबर नेहमी ठेवा. And these are the leaflets we have prepared in the local language, and we give to all patients who come with segment that don't go barefooted, avoid night walks. Rodent control is very important. Important point is to remember is that snake bites are also seen in metro cities. So avoid all these things. Community education is very important. Avoid tying a tourniquet, and a prompt, and 80% bites are dry bites. And most of the time it is this season, June to September, where you get maximum snake bites. Next. Thank you. Thank you very much.
Thank you, Sanjay sir. And I think this was one of the best lecture we had about the snake bite. And most important thing is the take-home message is very clear. So that is one thing, important thing what I noticed, and the pictures and mostly what we call this is implied in itself the importance of how to manage the snake bite and how to prevent it basically. So, sir, this is a wonderful lecture we had, and I think many people wanted the slides also. With your permission, we can share, not without
Yes, yes.
fear.
Definitely, sir, you can
Okay.
share.
We can post in the group, and anyway this presentation would be available on YouTube immediately
Yes.
once the session is over. So you can go through on YouTube.
Yes. So because of lack of time now, we need to go for the second session, and which will be taken by none other than our DIP man, Dr. Bakul Parekh sir. I just 2 minutes introduce the sir. So, sir, the only thing I wanted to share is your vision, what we called in your CV. Do not walk behind me. I may not lead you. Do not walk in front of me. I may not follow you. Do not walk away from me. I need you, and let us walk together and be friends. So this is the wonderful lines what we can take from you, and from your curriculum, your so many years of experience. We are having this wonderful friends like you in our, I would say, MAHIP and also the Central IIP. So welcome, sir. I request to start your session because you doesn't require any introduction as well, because you're a man who knows everyone. Thank you, sir. Please start your session.
Thank you, Satish, for your kind introduction. And I hope that you are getting my voice properly.
Yes, sir.
Yes.
Yeah, thank you. I'll share my slides. So
Yes, sir. Full screen.
yeah. So today's presentation is usual presentation and unusual diagnosis. Many times we know that we are bowled by googlies. A leg spinner will bowl a off spinner, but from his hand movement will not be able to recognize, like what you see with these three great leg spinners and one off spinner who is bowling the leg spin with the action of off spin. So all these googlies are there in our day-to-day practice also, where many cases mimic each other, no? And they have common presentation and they can fool us anytime. So if you do take thorough history and do clinical examination, 85% of the time you will be rational and you will be able to narrow down your differential diagnosis. And accordingly, you can do some few investigations and come to the right diagnosis. So let us go through some of the cases which we face in our day-to-day practice, and the journey of these cases will guide us as to what you should be doing and how you should pick up those clinical clues and come to or narrowing down your differential diagnosis for further management. So start with first case, 8-month-old child adopted from orphanage. Exact details of birth history was not available, though some vague history of NICU stay was present. And complaints of acute onset, painful restriction of right lower limb movement with fever. So a case of pseudoparalysis. And this was the picture where there was swelling and warmth over middle 1/3 of the leg, and there was severe tenderness and febrile. So naturally, we'll think of infection because signs of inflammation are there. And the child is febrile. So whenever there's fever, we always think of infection, though we know that all the fevers are not infective. The count was done 14,000, CRP was 18, and ESR was 48. So they were slightly raised. So we took an X-ray to see. So there was a periosteal reaction, if you can see here. And this X-ray was of the full lower limb. So we saw the other part also, upper part. And that also showed some periosteal swelling. So when there are more than 2 periosteal swellings, we always think whether there's a battered baby or whether there's a child abuse or whether the infection like osteomyelitis, or maybe there is something like syphilis because this was a child coming from orphanage. So we took one full skeleton X-ray, and that showed periosteal reactions everywhere, no, in upper limb, lower limb. And so we were thinking about the diagnosis. So if anybody can say what is the diagnosis, or I proceed.
Got the idea about general precautions.
Congenital syphilis.
Started her treatment, and since then she's following with us regularly. That's how she has grown.
Hello.
Initially, her
Child was otherwise,
dipped a little and then stepped.
Somebody is having.
yeah, there was a gradually increasing pain and warmth, and syphilis and other tests were done and they were normal. And when there is periosteal reaction everywhere without fracture, child abuse is also ruled out. There is no hematoma, there is no stiff tissue swelling. So this diagnosis is definitely Caffey's disease, which is known as infantile cortical hyperostosis, which is benign and self-limiting condition. It can involve tibia, fibula, clavicle, scapula, which is one of the most common involvement. And treatment is only rest, ice, and anti-inflammatory drugs like naproxen, maybe at times steroid, but there is no role of antibiotic. And usually child responds very well to this type of treatment. So take-home message is that all the fevers are not always bacterial infection, and all the infections don't require antibiotics. You have to think about all these differentials. Next case, 3-year-old male, suspected case of Prader-Willi syndrome with other neurological issues. And he was severely obese. It was 40 kg for a 3-year-old male child. So naturally, he was non-ambulatory. And he comes again with severe pain, swelling, and restricted movement of right upper and right lower lip both on one side. In any child had also sepsis and recurrent UTI, which was being treated, and has swelling over the right shoulder and right lower femur. So, and this swelling was increasing, and when X-ray was taken, it showed dysplasia of the epiphysis in the upper part of the humerus and also in the lower part of femur. So that's the reason which was leading to pain and swelling and tenderness. So again, another case of pseudoparalysis. So story continued. There was percent low hemoglobin when we investigated and done CBC. Sepsis was already there and swelling was increasing rapidly. So we did sonography, which suggested large subperiosteal collection with internal echoes. And naturally, when there is fluid, we have to always tap. So we did take the child for aspiration, and that aspiration showed totally hemorrhagic fluid. Diagnosis: non-ambulatory child, malnourished child, hemoglobin falling, swelling increasing rapidly. and with dysplasia of all the epiphyses, upper and lower bone on the right side. So hemophilia, you will have a different presentation, no? Or why only on one side? So basically, this is a case of scurvy, because all the ambulatory, treated with splintage, vitamin C, and blood transfusion, very commonly seen in non-ambulatory kids with poor nutrition. Another cause of pseudoparalysis. Diagnostic features are severe osteopenia, pencil thin cortex, and epiphyseal separation. And treatment is only with splintage, vitamin C, and blood transfusion if required. And prognosis is excellent. If you can appreciate this exercise, I'll show it again. See, there is a pencil thinning, and the bones are, the epiphyses are displaced. It is very classic, and osteopenia is already seen. So this is very classical case of scurvy, especially when there is a malnourished child and who is non-ambulatory. The final outcome was very good, completely calcified subperiosteal hematoma. Case 3, day 28, neonate, preterm, NICU stay, neonatal sepsis was treated, and discharged on day 20. The decreased movement of left lower limb for last 4 days. X-ray was mostly normal, and USG was reported as suggestive of dysplasia of hip with dislocation. So which is very common when you see a normal newborn NP, you have done some violent movements, and even otherwise at times. So naturally, I called my friend Dr. Mandar Deshpande, who is our pediatric orthopedist, who is practicing near my hospital. And I told him that we have got a case of CDH, congenital dislocation of hip. And so he asked me, by the way, how did you diagnose it? I said the child is keeping the limb flexed and resisting extension. And don't worry, USG also has proven to be CDH. He said, let me see the X-rays. And he sees this X-rays, and he asked me to do MRI. And MRI was suggestive of some collection of fluid around the head of the femur. And CRP was done 10, ESR was 28, there was no fever. So what was done? Drainage through the anterior approach, large amount of pus and granulation tissue was removed from that joint, and femoral head was relocated into the acetabulum, and culture got no growth and continued with IV antibiotics and then oral antibiotics, because all these bony infections, they require lots of antibiotics for a longer duration. And child was currently doing well after 1 year. Hip was stable. Proximal femoral changes were secondary to osteomyelitis. And then this X-ray, which shows complete recovery. So what are the points to we learn from this particular case? Congenital hip dislocation is never painful. Here the movements were very painful. There is never any restriction of movement in CDH, except for terminal restriction of late stage, where you get that click sound. But otherwise, there is no restriction of movement. So no pain, no restriction of movement. And in an NICU graduate with pseudoparalysis, where there is pain with restricted movement, always think of infection first, because many times in past, of course, we used to collect blood by femoral. At times when you don't get peripheral veins, people still do that, and that leads to infection most of the time. Prefer get an MRI done to diagnose the concomitant osteomyelitis. Case 4, a 9-year-old boy, native of Madhya Pradesh, symptoms since 3 months, and he has been showing to multiple doctors, and now he comes to me with anxious relatives. We asked, what is the problem? क्या तकलीफ है? सर गिर गया था और फिर उसके बाद वो उसका पैर में दर्द होने लगा. So we have shown to many doctors, many investigations have been done. It's an infected hematoma which is diagnosed by many doctors who have seen him, and it's just that the location is difficult, and that's why they were referred to Mumbai for better treatment. On examination, there was severe pain and tenderness over upper posterior tibia. Barely was able to walk with antalgic gait with equinus contracture. And all papers have suggest history of trauma, hence infected hematoma, and even attempted USG guiding tapping, which was dry. So when you don't get what you expect, you always have to think laterally and go into the details. So when did he fall down? 4 months back. When his symptoms started? Since 3 months. So there was a 1 month lag. Did you show anyone for the trauma? No, he did not tell anyone. It is only when he started limping that we insisted that he must have fallen, and that he said that he may have had a fall about 1 month prior. So this is usually a presumed thing whenever there is something like trauma and you feel that there is some injury. First X-ray was quite normal. Second X-ray shows the soft tissue swelling here, and there was pain and restricted movement. And then we did MRI, which confirmed that there was a collection of fluid around the head of the femur, which was ultimately drained and came out to be smear positive tuberculosis. And ultimately, we treated with anti-tubercular line of treatment and child improved. So again, what do you learn from this? Why do you think trauma is related to presence symptom? Because it was presumed, parents felt that he has started limping suddenly, so he must have got some injury. So points to point, parents like to relate anything in the limb to an alleged history of trauma, however remote, and this leads to infection being called as traumatic problems. And always try to ask whether there was a asymptomatic period after the history of trauma, and also whether they had sought medical or orthopedic attention immediately after the fall. If the X-ray is normal or not fitting with the history, disregard the history of trauma and start from zero and think of some non-traumatic diagnosis. So this was again a learning. Case 4, 4 months old female child, well-growing child, development was normal, only on breastfeeding, had diarrhea for 2 to 3 days, which was greenish, no fever, mostly breast milk diarrhea, looks sluggish, but there is poor cry, weak sucking, there is hypotonia, pupils were poor reacting to light. Vitals were normal, CNS-wise, there was no head holding, there was ptosis, there was hypotonia, and reflexes were suppressed. They were staying in a joint family. And so likely differential diagnosis was encephalitis, maybe sepsis, maybe Guillain-Barré, if the older child, metabolic and poisoning. So many things are there. So whenever there is sudden onset without any positive history, we have to think laterally. And by the time we come to some diagnosis, we had a history from grandmother that she was giving honey for leaking, gouty honey. No, they always feel that any honey which we get from the village is always very good, but that is impure and that can lead to botulism. So here it was suspected, difficult, though it is difficult to diagnose. You have to always keep in mind poisoning when there is sudden onset of such CNS event, where there is no other clear history, where you have ruled out everything. And then, of course, we have to think about this thing. And so this was a case of child who was being given honey every day, which was impure. Case, a 5-year-old girl comes with fever off and on since 16 to 17 days, increased intensity in last 1 week. No documented temperature, child well in interfebrile period, headache associated with fever was there, and some cough and vomiting last 2 weeks. So we thought maybe there is some viral infection, maybe some enteric malaria or maybe tuberculosis, because it was a case of fever for more than 15 days. And that girl had received multiple antibiotics and anti-malarials in last 2 weeks. And on examination, temperature was 101, significant, heart rate was 110, with respiratory of 60, mild pallor, low lymphadenopathy, icterus or no rash. Respiratory system was okay, but liver was 3 centimeters, spleen was 2 centimeters, both were soft. And there were no meningeal signs because of vomiting. We had thought of that also. So again, differential remains the same. Only thing is that with the prolonged fever, so viral is out. Typhoid can be there, resistant typhoid. Malaria, very common in endemic area. And if not treated, it continues to have fever. And tuberculosis, nowadays we are seeing many cases of tuberculosis, especially MDR tuberculosis. That also has to be kept in mind in our country. So what investigation you like out of these 4? Of course, I will go for the last one. There is CBC, malaria, CRP, CSR, culture, and gastric lavage for my tuberculosis, CT chest, and abdomen. And investigation reports came. Yes, CBC was not really very significant. ESR also was within normal range. Malaria came negative, Mantu came negative, urine and blood culture came negative. X-ray chest showed this picture. So this was a case of miliary tuberculosis. So where clinically we were not suspecting, there was no classical signs of tuberculosis except for the fever which was lasting long without any cough or anything except for 1 or 2 days. And there was vomiting, but there was a headache. And this was the picture in miliary. And miliary, we all know that is an imaginary spread. And so we have to definitely do CSF. And there was again a history of headache. So we did CT chest, brain, and CSF all together. CT showed again confirmed miliary mottling, brain showed basal exudate, and CSF confirmed tuberculosis. So a case of tuberculosis can mimic many things, and we have to keep it in mind always when there is a prolonged fever. A 12-year-old boy came with history of fever and increasing fatigue since last 2 weeks. He had some cold and cough for 2 weeks ago, which got better over days. However, the fever persisted, low to moderate grade, not documented. So in fever for more than 15 days, and there is fatigue. There is generalized body ache, breathlessness while coming up the stairs, and there is no headache, vomiting, sore throat, abdominal pain, skin rash, or bone pain. Now, breathlessness here, we know that breathlessness can occur only because of three conditions. Either there is hypoxia, or child is dehydrated, or there is blood loss or anemia, or maybe some cardiac issues. So, keeping all this in mind, we had asked for past history of pox contact and many things, but there was no significant past history of family history. So, differential again, viral is almost out, typhoid, malignancy, and tuberculosis. So here temperature was 101 with increased heart rate, respiratory was normal. So there was no hypoxia as such. Blood pressure was 116 again within normal range, so no cardiac as far as possible. And height and weight were 75th percentile, so grown well. So almost any chronic infection was out. He looked pale and tired, so definitely anemia. There was no rash or petechia. And bilateral cervical node, etc., everything was not palpable. They were palpable, but not tender. And liver was 1 centimeter and spleen was 4 centimeters. So spleen was more than liver with anemia and feeling tired, and there is no petechia present, and child had grown well till now, and now he has developed these signs. Other systems were normal. So for us, malignancy came first because any child who is around 5 years and above, you will get severe musculoskeletal problem, backache, or maybe pallor and increasing pallor and sort of fatigue. So we did bone marrow and did all the routine investigation, and bone marrow showed 15 lymphoblasts and 80 lymphocytes. So here the dictum should be, X-ray was wide mediastinum. So dictum should be any case which appears to be like behaving like tuberculosis, but doesn't behave like tuberculosis. Think of lymphomas or leukemias or any blood problems. Or whenever there is a case of measles and it doesn't behave like measles, think of rickets. A child who looks like enteric fever doesn't behave like enteric fever, think of brucella. A child who looks like dengue but doesn't behave like dengue, think of chikungunya. These are some dictums we should keep in mind. It may help you in your clinical practice. A 4-year-old boy presented with 3 days of history of fever, headache, and myalgia. The illness started with high fever, which has been same over the last 3 days. Child was active in the interfebrile period. So naturally, it can be anything, viral, bacterial, dengue this season. Maybe enteric can also start in the beginning, but interfebrile child was normal. So that goes against bacterial fever. Child was presumed to be having a viral fever, given antipyretics and advised rest and plenty of fluids as usual, and he developed rash on day 4. We started from his hand and feet and then spread over the entire arms and legs. He started from hands and feet and then spread all over, not started from cheek or face. He was admitted in the hospital for further treatment, and differential again was dengue because of monsoon season, maybe German measles by any of the viral with exanthema, or maybe rickettsia because this child was coming from Solapur. He was alert and responsive, but appears to have a little sick, and temperature was high with tachycardia and slightly increasing respiratory rate. Blood pressure was normal, and there was maculopapular rash that blanches under pressure on the upper and lower extremities, and a few scattered macular lesions located on the upper trunk and back, and rays predominantly involve palms and soles, and small heel scape lesion on this left shoulder, and minimal tenderness on palpation of the calf and thigh muscles, and all systems are normal. Hemoglobin was 11, total count was within normal range, platelets were a little low. There was 89,000. And serum sodium was 129 per liter. So this was the case where on detail, this is thanks to Dr. Janani Shankar, this is her case. And we found a scab at a place which was otherwise hidden. And then diagnosis was confirmed. There was rickettsia, and of course we have to give either doxy or chloramphenicol. We prefer doxy over anything else, and you get tremendous, fantastic response within next 40 hours. Many times we use therapeutic trial to confirm the diagnosis when rash continues further. Usually in measles, when rash appears, fever goes, or any other viral fever, when rash appears, fever goes. But if rash continues even after, or fever continues even after the rash, or if there is a palpable purpura, or maybe the maculopapulosis involving palms and soles, always keep in mind rickets. And when in doubt, rather than depending on serological tests, which are always dicey, you give a therapeutic trial and you will get an improved result in 48 hours, and that will confirm your diagnosis. A 5-year-old girl, fever for 5 to 6 days, high grade, no other symptoms, Hemoglobin was 10, total count 3,800, little lower. Platelets on the lower side. Malarial parasite was negative, dengue was negative, and his child was as usual put on IV ceftriaxone, but fever persisted. Blood culture came as negative, so almost entry was ruled out, but he develops an erythematous rash and is referred for an opinion. And this was the rash. Child was toxic and febrile. There was generalized erythematous rash, most prominent on face, hand and feet. One tender cervical node, and there was tender hepatomegaly and mild splenomegaly. So we always thought of a toxic febrile child as bacterial infection, and with such a type of rash, again maybe rickettsia. But our RMO, who was very smart, and he took a detailed history in the night, and he got the history as the patient had been started on carbamazepine 1 month back, first hammering and jittery movements of hands and feet. So before we do many investigations, this history came up, and then our diagnosis was almost certain. And we repeated CBC, which shows eosinophilia. So what is the diagnosis? Carbamazepine was stopped
Stress.
and started. Dress, yes, correct. So there was residual symptoms, there was a dramatical response to 1 dose of steroid. And then, of course, so drug-related hypersensitivity syndrome or DRESS, it is usually described with any anti-epileptic drugs and dapsone, but any drug can cause fever, rash, lymphadenopathy, hepatosplenomegaly, hepatitis, thrombocytopenia, and eosinophilia can give you the clue. It can be fatal if not picked up in time. And withdrawal of drug alone may not be sufficient at times, and you may need to give steroids. And mind you, even after stopping drugs, child may respond, but there can be ups and downs. Child can get recurrent symptoms, and over a period of time, then child recovers. A 3-year-old male child, fever for 15 days. He has received amoxicillin for a count of 13,800 neutrophilia. Platelets were 3.4 lakhs, followed by capnidine for 2 days. And still fever persisted. So even third antibiotic was started. We did one more pediatrician, and their repeat CBC was done because of the fever persistence. Again, there was increase in total count with neutrophilia, and now platelets are 4,90,000. And Vidal test was done because fever was prolonged and almost like a PO, and which came as O 1 in 160 and H 1 in 160. And when we say that Vidal test should be used intelligently, and when both O and H are positive, we think of entry fever. So child was put on antibiotics, both cefixime and azithromycin, which is again very illogical or irrational because you cannot use 2 bullets to kill 1 bird. You should have started with 1 antibiotic anyway. Vidal, we nowadays don't give much importance. We have to wait for the culture report. And if culture comes negative, we have to stop these antibiotics. So here, in this child, on detailed history, there were daily high spikes with interfebrile period being normal. Now in enteric fever or bacteremic bacterial fever, interfebrile period also child will be toxic or maybe it will limp and loose. There was no travel history, no significant cox contact, and macular rash without itching all over the body since 1 day, and child was irritable during fever. And there was anorexia, cervical lymph node was palpable, bilateral multiple, largest being 2 centimeter. Liver was just palpable, spleen was just palpable. So all sorts of differences were thought of, all the investigations done, they were all negative, but repeat blood counts was lower hemoglobin with count going to 35,000, again neutrophilia, and platelets increasing to 8 lakhs, and ESR and CRP going into 3 figures. So now you know that this is an inflammatory disease and not an infective disease, a great mimic. And in this child, this was the rash, maculopapular rash on face, foot, and there was little alopecia, but male child. So diagnosis is any inflammatory fever at this age,
KD.
KD or maybe Sogia. Those are Sogias, subacute juvenile arthritis. But if this was a female child in this alopecia, I would have seen, I would have kept in mind also differences SLE. Ultimately, of course, there are
Yes.
inflammatory disorders and treatment remains the same. So here this child was not very bad. So we start child on naproxen, and child responded very well. But uh, uh, I'll come to this little later. The same child, which is 3-year male child, after 15 days, he comes back after for fever and cough cold for another 15 days. And here this was there on the left side, and there was no complaint. And because there was otitis, he was investigated with increased count, but there was lymphocytosis this time. And platelets were normal, ESR was normal, urine X-ray was normal, ESF showed no growth, blood culture, urine culture showed no growth. But since there was otitis in a young child, which was significant with high fever and which was non-vomiting, child was admitted and was given injection ceftriaxone. at a dose which is higher, but there was no improvement. And now on day 6, that is day 21 of fever, child developed tachypnea. And as they developed hepatosplenomegaly, abdominal distension, and rash over the abdomen and legs. And this was hepatosplenomegaly, this was a rash. And count showed count of 23,000 with low hemoglobin, which is lower. Lymphocytosis, platelets were within normal range. ESR was 48, and Will-Felix test came positive. We know that these are all dicey tests, but then it is came positive. We put this child on doxycycline, but there was no response in 48 hours. So rickettsia was ruled out. This was probably a false positive test, and everything worsened. Tachypnea increased, there was icterus, there was ascites, in child passed some blood in the stool. So there was multi-systemic involvement and sudden worsening. And repeat count again was done, and it was compared with previous count. So there was a tricytopenia, hemoglobin low, WBC low, platelet low, and ESR was normal, but CRP was high. So the diagnosis suspected was HLH. So whenever a child who is responding initially and suddenly worsens with bicytopenia or tricytopenia with normal ESR, you always think of HLH and you confirm your diagnosis, or maybe increase your suspicion to a probable diagnosis of HLH by doing ferritin, which will be in thousands. But only ferritin is not important. So whenever in doubt, so when there is hyperferritemia with symptomology and tricytopenia, I will think of HLH and start steroid immediately, because any delay will worsen the prognosis. And why ESR is normal? Because in HLH, fibrinogen is utilized, and ESR is based on fibrinogen. But your CRP, the other inflammatory marker, will be high. So these are the things where, again, you can get triglyceride and SGPT, which can go up. But mainly your ferritin, and then if in doubt, you can do bone marrow, which will show macrophage, which is in ingested blood. So it can be mass macrophage activation syndrome or HLH, whatever terminology you use. So HLH is a great mimicker. It is well described after Epstein-Barr virus, malaria, dengue, or enteric. Most of the time, enteric fever, where treatment is started well, diagnosed by culture, and started responding initially and then worsens, always think of HLH, and you can start confirm by all these things. A 2 weeks male newborn born to primary gravida by seizure and is a borderline term, 35 weeks, birth weight was 2.1 kg. So was kept in NICU for 2 to 3 days on IV fluids and sugar monitoring, but discharged on day 4 because child was exclusively breastfed and child was fine. On day 13, his child become lethargic and with poor sucking at home. So he's brought back where weight is 2.3, dull, poor suck. So it was suggestive of maybe septicemia, suspected sepsis, and any sepsis you have to run meningitis. So blood culture, CSF, everything was done, and child was put on meropenem and birth spectrum, and CSF came normal, culture came sterile, and there was progressive increase in drowsiness, and now child developed seizure, and MRI brain was done, which clinched the diagnosis. This was the MRI. So there is hyperintense posterior limb of internal capsules and intense basal ganglia, which suggests it's the case of inborn error of metabolism. There is MSUP. So you will suspect this type of thing, and then you will do confirm by doing serum lactate, serum NH, ammonia, your proper paper chromatography, and diagnosis can be confirmed. So any patient, you should have a high index of suspicion. A newborn screening test may help in picking up this early and can occur at any age, especially after stress. And clues are culture negative sepsis and encephalopathy, low counts and platelets, non-response to antibiotics, acidosis, hepatitis, coagulation abnormalities, and these electrolytemias. And screening blood gas and lactate and ammonia can make your suspicion strong, and you can treat accordingly. A 19-month-old girl, fever for 4 days, swelling behind the right ear for 4 days, poor oral intake, toxic febrile child, right posterior infraorbital firm swelling, 3 by 3 with erythema and tenderness, received comoxiclav, cefadroxil, ibuprofen, everything, because child was worsening and everybody was getting panicky. Counts were, total counts increased with neutrophilia, platelets to 5,44,000, and CRP in 3 figure, and blood culture said which came later on negative. Initially thought of infection with say 4 years and antibiotics given, thought of tuberculosis, FNAC came normal, extension biopsy came normal, but ultimately case progressed, and even after antibiotics and other things, CB showed increase in count, increase in platelets, CRP 340, and so the suspicion was of again an inflammatory disorder, and diagnosis of after these findings of persistent fever, persistent irritability, lip appearing crack, red tongue, palmar erythema, decrease in size of cervical, it was Kawasaki. And this was the picture. So naturally, this child was given IVIG as per the protocol, and child responded, fever came back. So again, Kawasaki is a great mimic, should be kept in mind when there is any fever of without focus lasting for more than 5 days. In such type of CBC report, there is your leukocytosis, which is neutrophilic with thrombocytosis, and ESR and CRP may be in 3 figures. It can nothing else but an inflammatory disorder, because severe bacterial infection causing this type of symptomatology will decrease platelet, decrease count, or maybe increase count in tremendous number. So all these and blood culture can come positive. So all these things will help you in differentiating, and definitely you should be cautious about incomplete or atypical Kawasaki, especially in an early infancy, a 6-month child or below. If he has fever without focus for more than 5 days, and you cannot have any other confirming 5 diagnostic criteria of Kawasaki, still you should do 2D echo and color Doppler to look at coronary artery Z score and rule out coronary aneurysm. Otherwise, you can end up in big trouble. But what is not Kawasaki? Anything which is exudative, no exudative conjunctivitis, exudative pharyngitis, discrete intraoral lesion, bullous or varicella rash, or generalized adenopathy, definitely it is not Kawasaki. A boy with fever, diarrhea, and abdominal pain, a 10-year-old boy, fever, abdominal diarrhea, ileus, picture looked like dysentery, was given multiple antibiotics and metronidazole, but child didn't improve. And then on 11th day, he developed sore mouth. So we were observing this child, and he developed this subcutaneous nodules on both the scenes, and then the diagnosis was confirmed. It was nothing but inflammatory bowel syndrome, which you can definitely diagnose, but the differential is always tuberculosis, tubercular intestine, or Crohn's disease. So here, biopsy proved the diagnosis, and child improved with steroids and methotrexate, but it can mimic tuberculosis or infective enterocolitis, and extra intestinal clues usually give you the diagnosis. It's very crucial. So a practical approach in general pediatrics should be any acute onset high fever, first rule out infection, which can be viral, bacterial, or malaria, possibly by day 4 or 5, because viral infection will start, fever will start reducing by day 4 or 5, sometimes maybe 1 or 2 days later. But bacterial fever, either it will localize or it will increase, no? In case of bacteremic bacterial fever like typhoid. But when it is not so, most of the time all other bacterial infections are ruled out, except for maybe a resistant typhoid or tuberculosis. By the end of 1 week, infection can be mostly ruled out except for tuberculosis. And persistent fever in infection beyond expected period is immune-mediated complications, though rule out infective complications like it can be HLH or maybe immunological fever. And watch for localization, like if there is pallor, bleeding, hepatosplenomegaly, lymph nodes are enlarged, arthritis, skin rash, then of course you can have any immunological fever or maybe malignancy, and that of course will you allow to investigate and confirm the diagnosis. So the 3 most common discernible causes of FEO in children in order of decreased frequency are infectious disease, connective tissue disease, and neoplasm. Malignancy is a less frequent cause of FEO in children as compared to adults. And the first step in obtaining a complete and detailed history and conducting a physical examination. And physical findings change. It may not remain there, or it may appear in series, may not come up directly. So we have to observe the behavior and the progress of the fever as well as the signs and symptoms. And abnormality not originally present can appear subsequently, which may give you a clue. Autoimmune disease like vasculitis and persistent toxemia is there, then it is very unusual that it is an autoimmune disease. Multisystemic involvement in older children is not common with bacterial infection. So whenever there is multisystemic involvement, you have to think of other things. Bicytomania with high platelet counts may be a clue to vasculitis. High ESR with negative CRP can be SLE or Kikuchi disease, and normal ESR with high CRP, Kawasaki. HLH. High ferritin and LDH may be early clue to HLH other than normal ESR. And hypertension with fever, usually infections is ruled out. So do not forget to get ophthalmic opinion in FEO. Bone marrow must be done before starting any empirical steroids without confirmation of diagnosis. And antibiotics often do not work like antipyretics, and do not hesitate to reevaluate with repeat investigation. And when diagnosis is not over, kindly take an expert opinion, because sometimes disease doesn't come with a label on the forehead. And when in trouble, take history like a first year UG, examine like an exam going PG, look for clues like Sherlock Holmes. Remember, most of the children we see have not read Nelson and present often atypically, and please maintain faith in your clinical skills and judgment rather than starting the treatment and then starting investigating what you are treating. So practice makes man perfect, like Singham, and be very clear in your history taking and examination, and spare some time for patient in your opinion. Because we have done a trial where, along with Anand Sandila when he was alive, and we had found that as soon as patient starts talking, doctors always interrupt. But if you allow them to talk, they will not talk more than 5 or 6 minutes. And that is what that time, what is what they deserve when they pay your consulting fee. And then that generally gives you a very good clue to come to the diagnosis. Thank you very much.
Thank you, sir. Thank you. And I think you are our Singham of this topic today because the cases you have taken is really, I would say, what we commonly miss, frankly speaking, in the general practice. Because as a general practice, when you get a lot of patient, you tend to forget about the history, then clinical examination, and sometimes the obvious clue in front of you is missed. And this has been like, I would say, brushed up and taken in the like more confidence for the common pediatrician to manage a unusual cases. Thank you very much, sir, for your wonderful talk.
Thank you. Thank you for giving me the opportunity.
Sir, lovely
Yeah.
pictorial pediatrics.
Yeah,
It was
thank
learning with the pictures.
Yeah,
Yes.
thank you. Thank you very much. If there are any questions,
So
I'm
I
ready
think
to answer.
we come to
Or
the conclude. Yeah. Yes, sir.
if there are any questions, I am ready to answer. Otherwise, you can put your questions in your chat box and I'll answer later.
Yeah. I think the journey of these cases were so, I think, flow, and your talk was so smooth. I think nobody will have any questions, sir, because everything is crystal clear. And most important thing is the diagnosis what you have made is not just because of the investigation. There's a clues in the clinical also. That was the most important thing what we had.
Yeah.
So thank you both the speakers today, and I would say this is a memorable experience from the point of a practicing pediatrician also. And I request those who are not able to like see on the this, they can go through the YouTube again and see this webinar. And I thank MyIP for giving me as opposite as a moderator, and I thank Dr. Ram Gopal sir, Dr. Amol sir, and the team MyIP for this wonderful webinar. And both the speaker, Dr. Sanjay Joshi sir and Dr. Bakul Parekh sir, and our coordinator, Dr. Sanjay Joshi. Thank you very much, sir. So we
Thank
conclude
you,
the
sir.
session, sir.
Yeah.
Thank you,
Good
sir.
night, everyone.
Nice. Good
Thank
night, sir.
you. Good night. Night.